guys have to stop through the system.
Tell me.
I'm trying to interfere in this. You gotta take over.
You be in charge. Take over. You be in charge.
The traffic is so unpredictable. You're driving. We leave at the same time every Tuesday.
Don't give me any.
I hear you. I hear you.
It's true. Not only sometimes
It always seems to.
Oh, that's right.
You know, tank and but anyway. Yeah, so I just.
Hi.
How are you, sir?
Not totally awake. How about you?
Good. I saw I can see you at 8:45 today.
Oh, you did?
And you're probably not going to get there, are you?
So we just.
I'll be a little late.
Okay. I'll bring coffee and stuff.
Oh, okay. Thanks.
Absolutely.
Why? I didn't know. You have to drive down.
I'm going to be down there anyway. That's my day.
Okay. Okay.
Yeah. I'll just drop that stuff off.
Sure.
Yeah.
very well. She told me yesterday one of her mentors, one of her mentors, stopped and said, you're doing so well, would you be willing to mentor some of your classmates?
How are you? Doing good. Yourself?
I'm good.
Good.
That's one of the pride.
Oh, you got that on the computer?
Not a knife, sorry.
10,000 spoons, and all I need is a knife.
Oh, you got from the other.
73 years, you get to 90, you get to ski finally. Yeah, maybe Nick could ski for free.
Good morning, Nick.
Could ski for free at the resorts. You know, they keep raising the age though.
Are they?
You know, it's what's the Whistler in the 70s?
You know, it isn't.
Did it start? I would get the charge. I know they really. Wow, it's such a deal.
85.
Here's the
I put my mom at 8 years old.
So, you guys are good. What time is decent or family? Like the day after Christmas this year. Where's the
Yeah.
Around here, Crystal, they just started overall. It's also
Is it
a couple of times. Definitely shows. Well, when I charted overnight, it started very well.
Okay.
Yeah.
I think they'll have coupons, and every once in a while have a coupon deal.
Stevens is good, I think.
Stevens is
right?
right too, yeah.
Crystal's about an hour and a half, 2 hours.
Good. Yeah, more like 2 hours at least in my house.
For you in the city, Nick, it's probably about 15 minutes longer to go to Crystal. If the traffic is good. If the traffic is bad.
And the snow is.
Snow, this year Stevens has had the best snow other than Baker. And for one day in the United States, Stevens had more snow than any other in the United States.
That was actually a father going to Beaver Creek. They had
Beaver Creek.
40 inches of snow and they leaving behind 80 here. So.
Well, you think about some valleys, they don't get any snow, but boy, they maximize what they get. You know, they groom like crazy.
I figured that's what you did.
Of course.
Oh, just once, yeah.
Do they have
You know, I think.
overnight?
This year's joke here.
You can do it,
I'm doing fine. I just played hooky for the Midwest skiers, but I was rummaging around my desk. I have that same picture someplace.
I can't remember what year it is. I'm trying to look for it.
Not awake.
Yeah, well.
It's the burden of this meeting.
85 to 90 something.
Got lucky today, they closed 5:20.
30 minutes longer.
About half hour back.
Is that all?
Yeah, but you're close to Stevens, though, right?
Yeah, I'm about 65 minutes from Stevens.
Back up.
Couple of people should.
The good thing about this early morning is there's no traffic.
If you're going to be sitting over there, I thought you may want to get you to sit over here.
Very good, thank you.
Can't break old habits, I guess.
One of the things about getting old. Don't sit in the same place with the guy you are.
Oh, I can't believe that.
Primary care guy.
Even just for a family, teenagers, and mom and dad would be appendicitis.
Yeah. Nice.
So you like your best you can.
You're all done with the evaluations now? We haven't even started yet. You're already finished. Everybody gets fatal peanut anaphylaxis. Oh, we go full circle again.
Remember that about 20 years ago?
That's right.
You know, it's interesting with platelet activating factor. If you put the patients on Benadryl and Xanax,
Well, that's
you
right.
can block all of the constriction that you get with platelet activating factor as a mediator. The whole thing. Nobody knows why. And I've looked at that on and off for the last 20 years when I learned that, and still nobody knows why. So maybe they'll tell me today.
Just take a Xanax.
Yeah, well, it can be halcyon too, but you can't function with halcyon. It's one of the illnesses.
Well, there may be people you want. That's right. That's what you need. How was the
On Thursday they have the weekend.
Now that they're putting warning
This doesn't make any difference.
Ambien,
Because if they're coming, they're here, very proud of people working on it.
Solution for what? Maybe I would say the day after, probably back is Christmas Day.
my daughter's going
Oh, right.
do it about every third year or so. There's not enough change from it with
Yeah.
you know, as the precursor.
Super
Well, that's
that's all there is. This last time you're going to go to the alpha so many times in your life.
some of the external little trips there's some stuff
My uncle used to live around there, so I was always going to go down and he'd move over to because he lived in Temple, which is sort of, if you draw a triangle between Dallas, Austin, and San Antonio, Temple's right there. So he's about 60 or 70 miles from one of those. I get mine right over. That was
You know what it was?
my favorite place to go was
We got one day.
Like Chicago.
I went to a meeting downtown.
I sent you that thing.
Yeah. I got about 2 months.
That patient's
Yeah. I don't know why it's all mixed up.
heads up.
No, he wanted to talk about it. He wanted
And we're seeing her next week. Sorry.
Yeah, that's right.
Morning, John.
Not just me. Okay. I'm interested next year in launch already. European study.
Yeah, somebody got a nice Tesla. He bought 3 tickets.
Thank you.
Most of the time, no, there's all interesting arguments, boxes, protein circulation. I think we're done.
Oh, my doctor. I want to take my stats. I want to protect myself.
Oh, yeah.
I think that's part of the other part of it. Logically, houses are developing more and more complex mechanisms. I don't think Lucy had that trouble though.
I've got to remember what gas does. I don't know. How many T cells develop?
Yeah, probably not.
I broke it more
I think we'll see.
But there are some.
Symptomatic. She was starving most of the time. She didn't have good sleep for her shoes. That's all.
This is your experience, sir?
Yeah. She must have. Here we are.
So, if there aren't enough universities.
Used to wear a All right. That's the other guy. Good. No.
Why was he?
I know, but what they did was they
Oh, right.
Well, they could either take them to court or they could pay $40 million. I looked at it, ready to start laughing. I thought you had a visit in the ENT department between April and September. She should be getting followed up for free if ever she is. I told her. Yeah, she doesn't want to pay. See you. She should go get it for free. Everybody has our GSK rep here.
Let's go ahead and,
That's right.
that'd be good. That'd be good.
Let's go ahead and get started. Today we review the allergy meeting, and we got 1 hour or a little bit less to review essentially 5 days of scientific information. My general take on it was really an excellent meeting with a lot of good information. 5 people sent in information. Unfortunately, only 4 of us are going to be able to present. Melinda Rathkoff, very nicely up in Anchorage, sent in a presentation, and you've got it sent out by email, or you've got it on a physical piece of paper here. But with our new system, there's a time delay, so it's sort of technically difficult for her to speak from Anchorage. And Drew just tells me it isn't going to work technically, so each of us spend about 10 or 15 minutes. I'll go ahead and and get it started. Who left me here, and how does this thing start?
That's right. It shouldn't be evidence, but at least we are reporting.
Hang on here a second. It's advancing on this screen, but nothing we can see up there. Anybody smart in this room?
What do you mean? Complete ignorance. They can't get there. Go.
Oh, yeah.
Slide.
Come on, Matt, get up there, show your guy how to fix the computer. Go to the youngest person in the room.
The youngest person.
Get up there.
Projecting just fine here, but not up there.
Reset.
That's all right.
Watch, he's gonna push one freaking button.
Oh, he's mind control now. That's all right.
I can only raise the computer up and down. I can't make it go on and on.
Yeah, you're like, oh, well, we're done. I just put it in your memory. I just filled your memory bank. That's right.
Drew probably did this as a quiz for Len. He probably hit some battery.
You were smart. Oh, I don't know how to do this.
Where'd Drew go?
Well, it's Kevin's fault that Drew left the room. Kevin decided to change his presentation from the way he submitted it yesterday to today. Drew had to go do something to upload a new presentation.
Well, we'll give us a general comment. There you go.
Hey. All right, Matt.
Yeah, full screen. All right, so that's
So Matt, you get out of 3 months of your fellowship just because of that.
Woo! I found this picture when I was working at my desk the other day when I remembered, firstly, when allergists had hair, and secondly, when this specialty was easier. All you had to know was sort of wheezers, sneezers, and hives. Because I went to a lot of sessions on immunodeficiency, which I know almost nothing about, and it was just amazing to me how that field is advanced with the knowledge of the human genome, how this has gone sort of from phenomenology to really a very precise science. And I went to one session in particular where there's a website where there are new postings on a daily basis, essentially, of new syndromes being described in immunodeficiency. So I don't know much about this subject, but it intrigues me. So I'm just going to say a little bit about that. I thought the major themes overall at the meeting were immune development and immunodeficiency, a lot about the human microbiome, a lot about food allergy, eosinophilic esophagitis, and food immunotherapy, both sublingual and oral, comparisons of subcutaneous immunotherapy and sublingual, sort of again with the split between Europeans and Americans, thinking who's more efficacious there. I know that actually one of the companies just filed with the FDA in the U.S. for its 5-GRAS sublingual immunotherapy. And then the topic, and we're going to come back to these topics actually, obviously in the next year of presentation. There was a lot about epigenetics, which clearly is an area that intrigued Nick, and he gave us a presentation last time. We'll do that again. So one session that particularly I thought was interesting because I didn't know anything about it was the fourth day of a plenary session, I think on Monday. A guy named Holland from the NIH, obviously a brilliant guy, talked about mono-MAC syndrome, one of the more newly described immunodeficiency diseases. And when Lynch was here and we had all the screw up with the technical presentation, he touched on this, and we had a complete presentation. And this just sort of was an example of how elegant the basic immunology is. So this is a relatively new and rare immunodeficiency. I think there are only about 25 people that they've reported on it. And they know specifically that it's a defect in GATA2 transcription factor. The clinical syndrome is people who get atypical mycobacterial infections, monocytopenia, also NK and B cell deficiency and defects. They get infected with papillomavirus, herpes virus, fungal infections. Interesting, they get alveolar proteinosis severely. And one thing I didn't understand is why they don't have monocytes, but they have alveolar macrophages. And I couldn't find anything in the literature to explain that. I thought that one of the stem cells for alveolar macrophages was to have monocytes that develop in tissue into macrophages. Lymphedema, and they can get myelodysplasia and acute leukemia.
I think it's because all the monocytes end up in the tissue as macrophages, and they stop, because this is an acquired thing over time where they lose their monocytes, and I think they end up all as sort of non-functional macrophages in the tissue.
And then can't generate any new ones?
Because it's not a defective birth, it's something that happens over time.
All right. So that intrigued me to look into what's known about the transcription factors, because he touched on this in his presentation. And this is just some of the terminology, which, again, for those of you who are young and learn this immunology is probably straightforward, but I was just wondering where all these definitions came from. It's pretty well known which transcription factors are involved in different T-cell development here. So this is just some terminology. The GATA stands for transcription factors which bind to GATA sequence of DNA. There are at least 6 of them in human biology. 1 through 3 are involved in hematopoietic stem cell development, and 4 through 6 in somatic stem cell development, such as liver and heart. T-box transcription factor expressed in T cells is what T-bet means when you see that in the literature. ROR gamma, I don't know where these definitions exactly started, is T-retinoid orphan receptor T. FOXP3 that we know pretty well is forkhead box protein 3, and STAT that we know best is signal transducer and activator of transcription. The reason I did that is as you look at T-cell subset development, it's fairly well worked out now that naive T-cells, when they're presented antigen in an MHC2 context with dendritic cells, can evolve into at least 4 well-known subsets of T-cells, and it depends on what transcription factors are upregulated and what signals they see to become either Th17, T regulatory cells, Th1, or T2. This is just a schematic. If you're really interested in this, there's an elegant paper by Bill Paul in Immunologic Reviews. It just came out about a month or so ago that goes into this really in pretty great detail. So in simplistic sense, as I said, dendritic cells plus a foreign antigen peptide presented in the context of MH2 to naive CD4 T cells can develop into any of those 4 subsets depending on what transcription factors are the dominant ones that are leading to T cell progression. So they become Th2 cells in the context of GATA3 and STAT5, Th1 cells with T-bet and STAT4, 17 cells with ROR gamma and STAT3, and T regulatory cells with FOXP3 and STAT5. And that's a great simplification because if you read the literature, it depends on the strength of the signal and other associated factors, but that's enough for me at any rate, just remembering that till the end of this session at least.
Maybe.
Then there was another interesting session on immunodeficiency which intrigued me a bit too because it carried on from that. It's been known for a while now that hyper-IgE syndrome is a STAT3 mutation, which makes sense from what I just said. That's needed for Th17 development. And we now know that Th17 is really essential for mucosal defense against Candida. And then there are a couple of other interesting syndromes where you see somewhat of the same clinical presentation for related reasons. So autoimmune polyendocrinopathy also develops chronic mucocutaneous candidiasis. And here the reason is that they interestingly develop autoantibodies to their IL-17. It's not that they fail to produce it, in the context of also making more conventional autoantibodies to, say, parathyroid and thyroid and adrenal tissue. And then there's yet one other rare, newly discovered syndrome called CARD9, which I knew nothing about, so I looked it up. Another rare disease where you get chronic mucocutaneous candidiasis and even invasive candidiasis. And again, the common theme here is you need normal Th17 immunity to protect you against cutaneous or invasive candidiasis. And again, it's because they have a failure to have normal Th2 cells, and they also have an impaired signal from their innate recognition receptor, part of the innate immune system, called dectin-1. So anyway, I learned a little bit about immunodeficiency. Switching categories here, I went to a couple of sessions on eosinophilic esophagitis, which remains a confusing area, to me seemingly a distinct disease in children and adults. But just a couple of take-home points. Milk is the primary trigger in children, milk and wheat in adults, although every adult that I test is skin test negative to all the foods I tested too. Skin test data in adults has a poor predictive index, but a good negative predictive index. So if they're negative, basically no need to avoid the foods that you've tested. Then you have to refine that as to whether you're talking about just skin prick testing or patch testing. I got the sense that there isn't too much added by patch testing. And then one particularly good paper was reviewed here that was in JACI in 2012 by Henderson as the first author. This is out of Cincinnati. The remission rates, which was mostly defined by repeat biopsy and showing eosinophil counts dropping, elemental diet, so this was in kids but also adolescents up to about age 18. Elemental diet remission rate 98%, the 6-food elimination diet 81%, and then skin test directed 65%. The conclusion from the things I went to in the literature is basically the empiric 6-food elimination diet is as good or better than skin test directed diet.
I was in one session with Hugh Sampson where he said that milk alone would give you somewhere in the neighborhood of 85% benefit when you got to milk and wheat. This is without any skin test directed. This is just, instead of the 6 foods, milk and wheat would give you in the low 90s.
Really?
Yeah.
Kids or adults?
I thought it was. Yeah, but it goes along with that, but you could limit it even to 2 foods instead of 6 foods.
And Len,
yeah.
I always pitch to patients and also referring docs that it's the negative predictive value that we're doing skin tests about, so we can rule out foods. And then also with milk, it's such a poor predictor, both negative and positive, that it's almost worth not even doing.
Yeah, that's right. That's right.
Either way.
People made that point that you just empirically avoid milk.
Yeah.
The skin test is of really little value.
So the value to rule out.
Yeah.
But then how do you explain the dichotomy that an avoidance diet fixes them and then the skin tests are no good?
It's not
hygiene.
Yeah, I don't think there are answers in this
Well, I mean,
field.
that's one answer. But I mean, so that's the question I get from the referring docs is like, well, if they're negative on everything, why does an elimination diet fix them? And I said, because we don't understand the mechanism at this point.
Right. The thought is that there are delayed immune mechanisms that we don't pick up. That's why people went to doing patch testing.
No, but even patch testing isn't any better.
Particularly helpful.
Are there any of the elemental diets?
You're in the Midwest.
Yeah, that's right.
Any of the elemental diets tolerable for adults yet? Because they've come out with 2 new ones in the last couple of years. And from what I knew, they all stink. Is there any good ones yet?
Literally.
Yeah, literally.
What wasn't discussed, I don't know. There are just 2 abstracts on a totally different subject here that intrigued me. Is there such a thing as a hypoallergenic dog? So here's a paper where they measured the major allergen in the saliva of 4 breeds, actually 5 if you look at the data, 8 dogs in each breed and sampled them every 2 months for a year. And the answer is basically no. Obama's choice was a bad choice. And I spoke briefly to her. She said the lowest breed are Labradors that are trained to be leader dogs for the blind. And she just is supposing that it's got something to do with the temperament of these dogs, which is just a guess on her part.
Since it's a bigger dog, it would put out twice as much, wouldn't it?
Wait, one at a time, what?
Since it's a bigger dog, wouldn't it put out twice as much, so it's a wash?
So to speak.
Yeah.
I don't know.
Well, it says about half as much, but
yeah.
Labradors, or if that's per cc, but Labradors are 2 to 3 times as large as the other dogs.
Yeah, I don't know if they
the
sell
size
it
would make.
anymore.
You don't carry them in your arms the way you do with Chihuahua.
Anyway,
I
I think the answer for patients is basically no.
There was a paper in Jackie in the last few months that measured antigen in houses with that same kind of span of dogs, hypoallergenic and not. Found the same amount of antigen in the houses.
Yeah, of all different breeds.
Independent of the breeds, yeah.
And then this is one trivial little clinical paper, but again, something that's topical right now, with this just having been released. They did a paper, actually it came out of the MGH, although when I went to the poster board, it was not up on the poster. You had to just, I don't know why they didn't present it. But it was a pretty big study, 693 people, and they actually simulated an emergency and gave people either an EpiPen or the AviQ device in a random order, and then had them simulate use and ask them what they thought of the two devices. And as you can see, really fairly overwhelming preference for this new device, which was statistically significant by all these comparisons. So that's all that I've got. We've got a lot of diverse information. I'll let Matt pick it up from there.
Now that they finally approved the law saying that schools can have EpiPens, now they're going to come out with a new device. They're going to get another
It's not approved yet.
It's going to be there because the nurses signed off.
Yeah.
It's interesting to me in the Seattle paper the other day, they used the word EpiPen, the brand name, in the byline of the paper.
You did, yeah.
At 5x.
Yeah.
So this is not meant to be an overview in any way. It's just 3 topics, things I sought out information about that I found interesting that are certainly going to change my practice, and I think just in my observation of how a lot of people in the community here practice, things that could potentially be improved, and that we're going to work on it and changing at the UW and children certainly. The first one just has to do with drug allergy, which is an interest of mine. And the speakers in one of the sessions, 3 of them, who I focused on down below there, and then also went to another one with Dr. Kahn, and mostly focusing here on antibiotic stuff, which is something we all know about, but I think something these speakers really said it's our job to address, and we don't do it aggressively enough. And then I'm going to talk briefly about desensitization, which is work that comes out of the Brigham that I was fairly familiar with before the meeting, and it was good to see a refresher on. So first off, this was Dr. Solinsky, who really stressed the negative impacts of carrying a diagnosis of a penicillin allergy and just having this on your allergy list, whether or not you're truly allergic, and we know 90% of people who carry it are not. So first off, he just showed that people who carry this diagnosis of a penicillin allergy overwhelmingly or to a significant extent get these other antibiotics, and focusing on, I don't think I have a point, here we go, vancomycin being quite a bit higher, and then fluoroquinolones being markedly higher. Also to some extent broad spectrum cephalosporins, 3rd and 4th generation cephalosporins. And then he basically went on to show that there's very strong data showing that people who get these antibiotics, so this is in a MICU, so vancomycin, broad-spectrum cephalosporins, and fluoroquinolones are at much higher risk of developing multi-drug-resistant organisms. This one showing specifically VRE. You can see a much higher odds ratio. And then also, same thing with sort of secondary infections, so C. diff, fluoroquinolones, even though this is classically described with clindamycin, fluoroquinolones are far and away the highest risk for developing C. diff, and you can see that penicillins down at the bottom are really not at significant, did not increase your risk of C. diff.
This is fascinating because I get less diarrhea with quinolones than with the beta-lactams.
Well, I think diarrhea and C. diff being different.
Well, I know, but still,
but
it's easy to put those two together.
Yeah, I definitely see that. Anybody who gets diarrhea, you can think about testing. And this really reflects what I saw as a resident too in the hospital, that we use a ton of these. This is really a big issue for residents out there who see a lot of people come in with a penicillin allergy, end up getting vanc or a fluoroquinolone, and you see a lot of C. diff secondary to this.
Why do you think the risk of C. diff is higher, statistically higher with cephalosporins, but not penicillins, which are pretty similar in their spectrum?
You know, I don't know. This is obviously just clinical data. He implied that this is largely due to broad spectrum cephalosporins, which are probably being used more than narrow spectrum penicillin. But that's just my guess.
Does it have anything to do with overall use, though? I mean, if you look at what drugs are used in the community, I mean, the fluoroquinolones and the cephalosporins are probably the number 1 and 2 drugs used.
Right. I mean, this is inpatient first off, but I think this is adjusted to the frequency of use. So this is an odds ratio based on an individual's risk of developing C. diff based on what antibiotic they got in the hospital. So they really made this point. So there's no direct connection that nobody's done the study of if you have a penicillin allergy listed, you're more likely to get C. diff, but it's a natural assumption to make. So basically, take home point from that, they're at much higher risk of getting these, and so both vancomycin, fluoroquinolones, and broad-spectrum cephalosporins. I didn't show this, but they showed a number of slides showing that this significantly increases the cost to the patient, and they've done that study, so anybody with a penicillin allergy is going to have a more expensive bill coming out of the hospital based on antibiotic choice. And then probably they're at higher risk for multi-drug resistant organisms and C. diff. And basically using this to plead to the audience that we should really use our skin testing for penicillin, which we know is highly sensitive and specific, to rule out or to get this off of people's allergy list. So then success of penicillin skin testing in decreasing the use of these broad-spectrum antibiotics, they had a number of studies here. You can see, in each of these, a significant decrease in the use of vancomycin and fluoroquinolones after patients have been skin tested. So I think something we should be doing in our clinics. Can lead to cost savings and will likely decrease the risk of these organisms.
What about the flip side for the people that are allergic? Does that mean we should be using more macrolides or?
I think it's a fair consideration.
No.
These docs didn't talk about it. I would think that's a reasonable approach. I mean, fluoroquinolones I think are overused, and this would, I think, add to the rationale as to why we should avoid them. So yeah, if you can get by with, it obviously depends on the infection, but if you can get by with a macrolide or even something like a gentamicin or the like, you have to weigh the other potential risks of not treating the infection or other side effects. But yeah, I think avoiding quinolones and vancomycin is a fair thing to do.
And sulfonamides wouldn't be a
sulfonamides
choice in there?
Sulfonamides were good. I think back in that one slide I'd shown, I wasn't on there, but those generally, I've seen other papers that those really don't breed antibiotic-resistant organisms. So I think sulfonamides are a good choice.
One more inane comment. 100 Costco, 100 Cipro is $21, and 100 clarithromycin is $200. So it's a tenfold difference in price between outpatient treatment with a quinolone and a macrolide.
Yeah. Well, I don't know why that is. Clindamycin, right? You think it should be cheap. You said clindamycin or clarithromycin?
Biaxin is $200 for 100 pills.
Like generic?
That's the generic price, yeah. And then if you get Cipro, 100 pills is $21.
Well, yeah, and you'd be one of the rare ones if you are giving Cipro. Most people, give either levaquin or moxifloxacin, which moxifloxacin is pretty expensive. So, so I think we're obligated. We really should be skin testing these people in our clinic, even if that's not why they're there, because getting it off their list, I think, is very valuable. For people who are just going to go for routine surgeries or end up getting admitted for pneumonia or any other number of things, which we don't think about a lot as outpatient docs, but coming off a residency, I can tell you it's definitely a big issue. So then the other issue that I found interesting was, so people with a penicillin allergy, is there really any risk with a cephalosporin, and do we really even need to test? And these speakers argued that, this whole myth of a cross-reactivity, it's probably time to kind of throw it in the waste bin. They put up this slide, which shows, and so these old studies from the 70s, this increased risk of reacting to penicillin or to cephalosporins if you carry a diagnosis of penicillin allergy. Trying to point, but that's the first two up there. But then really in more modern studies, so the Goodman and Delott here, that there's no appreciable increased risk in these large studies. So you can see that one looking at 600 patients who carry and 22,000 who don't, not really a significant increase. They had one patient reaction out of 606 with a questionable reaction being eczema.
Does second and third generation cephalosporins have a much lower rate?
This included first generation.
Yeah.
And that whole myth of first generation, I mean, I think, the authors made an argument that you need to be aware of that potential risk, and maybe that is a good place to skin test, but that probably the cross-reactivity, even with first-generation cephalosporins, is not valid.
But I think to Art's point, maybe the first two studies, it was mainly cephalexin. Probably.
It probably was, although, I mean, I don't know exactly how things were in the 70s, but I think even back then, some of these cephalosporins were contaminated with penicillin.
Exactly.
And that's the real reason why this myth got started.
EpiPen for testing back then.
There was this last study from 2005, Fonacer clearly showed, they found 7 out of 3 patients who seemed to have true reactions to cephalosporins. But, this is one study. The authors sort of called into question. There was no control group. So again, arguing that probably this is something that's going to, at some point, kind of end up in the dustbin of allergy history. There's a cross-reactivity. So in general, they argued that administration of cephalosporins is probably universally safe in patients with a penicillin allergy, and you probably don't even need a skin test. We often still do, especially if the reaction was anaphylaxis, but if it was a mild reaction, they really argued that you probably don't need a test. So they just made a point. They didn't show data for this, but that basically Mayo Clinic has a protocol in place that all preoperative patients with a penicillin allergy will either just get a cephalosporin, or if they have a history of a severe reaction such as anaphylaxis, they'll go ahead and skin test and then give it. They didn't show the data, but they said it's been highly successful. And I think it's something Drew and I are going to try to implement here. And then another useful data I came away with from this talk is that one of the frustrations I know we have at the UW, and I think a lot of clinics have, is that you have to make up the penicillin in real time. It degrades in a week, so you can't, at the UW we have to bring the patient back after our pharmacy can mix it up. But what they do, I think he's in San Diego, is they just keep all of these, any beta-lactam frozen at -70, and it's good for at least 6 months. So we're going to implement that at the UW, start keeping all of these things frozen at -70 so we can test in real time for our consult and for our clinic patients. So, and that's basically just what things that Drew and I are going to try to improve at the UW. So implement a pre-op questionnaire for UW patients with a penicillin allergy to get them a cephalosporin or get them skin tested and get them a penicillin, and I mean a first generation cephalosporin. Rather than, right now the protocol is give them vancomycin if they have a penicillin allergy. We're going to do it if there's no history of anaphylaxis. If there is, then they'll consult us and we'll skin test them first, is sort of the goal. We're going to have pre-made dilutions of penicillins and all the other beta-lactams that we routinely skin test for frozen at -70 so we can use them in real time. So that's what I wanted to talk about with drug allergy. Something, again, it's pretty mundane, but we can really do a better job. It's sort of our job to get this off of people's allergy list. Following it, Dr. Sloan gave a great talk about antibiotic desensitization. This is a protocol that he, Dr. Castells, and others at the Brigham have developed over the last decade. I don't know how many are familiar with it, but it's this 12-step protocol that they've really promoted. It's nothing groundbreaking. It's a little bit different from most other protocols based on the rate at which you're advancing the dose. And it's also something that they've built a lot of flexibility into, and I would reference the paper that I failed to include there, but I can send it to anybody interested, and it's easy to find if you just look up Castells desensitization. And basically, they've had now, when I was there, was 2,000. They've now had over 3,000 successful desensitizations to chemotherapeutics, monoclonal antibodies, and antibiotics with only one failure, which I think is a better success rate than anybody here or anybody else in the community can really promote. And I think it is applicable broadly to really anything you want to desensitize to, and I think we're going to try to implement it as sort of a standard procedure at the UW, or I'd like to see it.
The normal desensitization of penicillin is, back in the old time, where like me days, is like a day to day and a half. They're taking 3 days here. And
no, this is not 3 days. This is 6 hours.
A few hours.
Because I thought you said 3 days.
The current protocol is 3 to 6 hours.
6 hours,
okay.
Or less.
I'm sorry.
Each of these steps is 15 minutes. Sometimes they'll lengthen a step based on a history of a previous reaction, but it's a quick, highly effective procedure. Dr. Sloan went on to discuss the theory as to why he thinks this works. I didn't have his slides yet. He just sent them to me last night. It was very interesting. He made a sort of physics-type argument showing that what he believes is that this has to do with the rate of acceleration of the antibiotic. He doesn't have any hard evidence to support it yet. He's going to try to do it in animal models, but basically showing that the rate of acceleration of administration here is based on the natural logarithm, and using that to postulate, it was pretty crazy, but he was comparing himself to Isaac Newton, describing the magical force as to why this works. But regardless of why it works, it's highly successful.
Did he pre-treat?
So pre-treatment is not necessarily a standard of this, but based on a previous reaction. If they have a previous reaction, immediate or delayed, they'll pre-treat as appropriate.
I know Castell does with chemotherapeutics has a heavy pre-treatment protocol.
She often, most
of everything,
on it, which is fine. And the argument also he was making is that you can push with this protocol. You can really push through any mild reaction, and that you should. A large number of these 3,000 do react, but it's mild, and you can, they push through it. So, again, it's nothing profound. But
do they continue this protocol if they're reacting, or do they
they'll tailor
the reaction go away and then?
If you read the paper, they'll adjust it a little. So they'll often add in additional pre-treatments at different steps based on when the patient reacted, or they'll lengthen a step if they react always at a specific step. So they kind of adjust this in real time on a patient-by-patient basis. In the paper, they describe how they do that to some extent.
Do they recommend leaving these people on penicillins after they're done desensitizing them?
You can. So once they've been desensitized, they can remain on it. They generally repeat this desensitization every time the patient needs it. So for a weekly chemotherapeutic, these patients are getting it every week, but they're generally getting it in the outpatient setting. They don't have to be hospitalized. They don't have to be in the ICU. And it's safe and effective is their argument. So anyway, it's something, I just think they've done a lot to advance the field in making this a standard, and they're really trying to promote it as something we should all use, and I think with good reason. So that's that. How much time? I'll just be quick on these other ones. So basically, my proposal is that we use this more as a standard, and we're going to try to set up an automatic order setting view for it. Briefly on CVID, this was Dr. John Routs, who was talking about interstitial lung disease and CVID, which is a common problem. I don't know how many CVID patients everybody has, but about 10 to 20% of patients get this severe, at times, life-threatening lung disease that's associated with, here increased mortality. And we really have no standard of treatment. So a variety of things have been tried, steroids, immunomodulators, but it's all sort of just, one-offs. Nobody's really studied it in any detail. There's no consensus on how to treat it. Most people now believe that steroids are really not effective, which is kind of the standard of care. And one of the reasons he's argued it's difficulty to study is because nobody's putting their patients into this U.S. immunodeficiency registry, so you can't look at what's being done across the country. So his goal is basically to study a standard therapy, and he picked, for a variety of reasons, rituximab plus azathioprine to treat this. He showed a paper that is not anything large, it's just 7 patients, but it's gotten a lot of attention in the community, here locally from Suzanne and Troy, basically a retrospective analysis of 7 patients with a biopsy diagnosis of this condition who were treated over basically an 18-month period with combination rituximab and azathioprine. And the short of it is all these patients responded pretty dramatic, or many of the patients responded quite dramatically. The main score I think to focus on is the one on the far end, the total high-resolution CT score. So you can see pre and post that most of these, 5 of them in particular, had a very dramatic response. And here's an image that he showed of one of them pre-treatment and post-treatment. And you can see a pretty marked improvement. And you don't get this with steroids, and this has not been sort of shown. Most people were happy if we can stabilize the disease and prevent progression. So this was the first sort of well-documented case series of real regression of the disease. What he's going to do is try to expand this into a prospective trial. He's coordinating with Suzanne and Troy here. We already have a large collection of patients at Children's and VIEW who are good candidates to enroll in this. So my plea would be anybody interested who has these patients in the community, hopefully we're going to start enrolling in that trial pretty soon. I haven't heard a date, but Suzanne, Troy, and Dr. Routes are all sort of in contact. I think it's something that is needed because this is a common and real problem for these patients, and it would be the first good study of a potentially useful treatment. And then he also made a plea that we really should be logging our CVID patients in this registry.
I'll
stop there.
Let's move on to Kevin.
So
I've been accused of nepotism.
Mark, how much time do you need?
Drew, can you make it a little lighter in the room?
Lighter? We have to share 17.
Okay, give me 5. Give me 5.
All the handouts and abstracts are on a flash drive. I have one extra copy if somebody wants it. I brought it. Although I must admit, actually, almost everybody who was a plenary speaker did not turn in a handout. So it's basically blank. Yeah.
It changed while I was here.
Len, is there any talk at the Academy of streaming it online? So you could just go to the Academy meeting from your couch?
The program they sent out ahead?
Yeah, just have the whole meeting broadcast online.
So I wanted to talk about peanut component testing real quick. This came up in the meeting in a few different sessions. And then a quick update on some food topics. So this is a kind of by way of example of a complicated patient I saw recently. So this is a kiddo who parents actually presented wanting a peanut challenge. And so they gave me this story. When he was a year old, he had peanut butter in his spine. When he was a year and a half, he just brushed against peanut butter and got a rash. He had positive skin testing at the time. And then about 2 years ago, he had no prior or no subsequent exposures, but he had a large scratch test to a fresh peanut extract and then a very low whole peanut specific IgE. In the past year, parents heard about the procedure and had him retested. He had a 5 millimeter wheel, again, to the old extract, not the fresh peanut. But his whole peanut specific IgE jumped up to 11.3. So the question is this kid a candidate at all for an oral challenge given his variable history in testing and what I would consider a fairly weak history in the past? So let's look to the past. This is Sampson's article in 1997 trying to correlate specific IgE levels and the predictability in terms of what would happen during a controlled food challenge. Keeping in mind our child here, his most recent was 11.3. So focusing on peanut, pointer. Oh, there it is. So this kid's at 11.3. He comes in somewhere between the 90th and 95th positive predictive value area. So basically this kid is not going to pass a challenge based on these numbers. what's interesting about the peanut numbers is that if you're at even 0.35, you have at best an 85% negative predictive value. So not exactly that sure about those numbers. So if you look at Perry's data from 2004, this is also a large group of atopic kids. She actually divided them into group 1 and group 2. So these are kids who have a known reaction, and then group 2 is the kids who have a very questionable history, or maybe were diagnosed just by positive testing alone. The decision point was sort of a go or no go. So in other words, do we recommend doing an oral challenge or not based on the numbers? If you were in this group of known reactions, a level of 2 is probably sufficient to suggest going on to a challenge. And if you have a questionable history, then 5 is probably the cutoff. Again, our kiddo was 11.3 with this contact rash from the past. So based on the 2004 data, he's probably not a good candidate for challenge. So I wanted to be the first person to do a study of new in practice, the spinoff from JCI. And you're probably familiar with the different peanut components. There's ARH1 through 9 for the most part. And for our purposes, ARH2 is the most important. It has the strongest correlation with clinical reactions. It happens to be a heat stabile protein, whereas ARH8, by comparison, is it's labile, and it's also homolog to BETV1, the major protein in birch. So what's interesting is the regional variations in these different peanut proteins, and Sisher goes over this in his article in this new issue. But anyway, in Spain, for example, it's primarily RH9, this lipid transfer protein. In Sweden, it's RH8, so it's not a coincidence probably that there's a lot of birch pollen in Sweden. In the United States, curiously, we have more of these stable storage proteins, the RH1 and 3, and this may potentially be related to our higher rates, if we have higher rates of anaphylaxis. Let's see here. So Sisher did a good job sort of describing when is it a good time to do component testing. And so it's more helpful if you have mild or no reaction in the past, a remote clinical reaction. You have this really narrow range, so between 0.35 and 15 on the whole peanut specific IgE, hopefully birch sensitization, and then patients who are a little bit older. And I highlighted where this patient of mine sort of falls in. He had sort of a mild reaction, maybe no reaction. It was remote, and his level was 11.3, so he's in the sweet spot here in terms of the total number. Again, this is the whole peanut IgE and not the component yet. So it's less helpful if you have a recent reaction. That's kind of confirmatory of the allergy anyway. You have peanut levels that are extremely high or extremely low. So we know that they're probably not allergic or probably yes allergic. No birch allergen allergy, or no birch allergy. And the thing about this kid is I haven't tested these yet, so I haven't been able to go back and look and see if he has birch allergy. I did a call to Fadia, or what they call it, Thermo Fisher, and the new test is called the Peanut test. And this is a very proprietary test. It takes a special kit, special arrangement, special lab. You're looking at the 5 components, 1, 2, 3, 8, and 9. It's a $300 test billed directly to the patient. And I'm not sure yet, I don't know if anybody's done this or not, but how well insurance companies are going to reimburse this. Has anybody ordered this yet?
Yeah, I've done about 6. The answer is 0.
Oh, so 0.
0 out of 1.
Okay, 0 out of 1. All right. You know, I framed this to the patient's family. I said, look, it's $300. I'm sorry that it's out of pocket, but we can do our best to get it reimbursed. So I sat at the Committee for Adverse Reactions to Foods at the AAAAI, and there's a survey coming out about perceptions and attitudes of oral immunotherapy. And there's a really wide variety in terms of, do we want to do it or do we not want to do it? I think one of the more prevailing attitudes was if the AAAAI doesn't want to lead, then they should get out of the way and let people do this. The others were sort of saying, no, this is a horrible idea, let's wait. We kind of put the last nail in the coffin, so to speak, about egg allergy and seasonal flu vaccine. Kelso actually presented the data, and he wondered if anyone had ever reacted to egg and vaccine. And then lastly, the epinephrine in school topic. There was a movement to get a database of all epinephrine administration in schools. So some states have mandatory reporting of epi events, and some have no reporting at all. Washington's kind of a mixture. We have some reporting, but not mandatory. And then, like Washington State, there's laws pending right now for unassigned epinephrine. So in our law, or our bill rather, it flew through the Senate a few weeks ago, and it got held up on its way to the House. The school nurses had concern about non-nurses making the quote diagnosis of food allergy or anaphylaxis in kids who had a first-time reaction. There's been a compromise, and I'll kind of skip to the bottom here. In the Times, they reported that SNO, which is the School Nurses of Washington, agreed that we will move forward with the bill as long as only nurses will give undesignated epinephrine to undiagnosed kids. So these are the kids who have like that first-time B reaction, the first-time food reaction. That will be the school nurse who can give epi. In all of the cases, though, kids who have a prior diagnosis have their own EpiPen, have their own action plan. Anyone in the school who's been designated can give stock epinephrine to those kids. And so going back a little bit, we're going to need providers to get on board with this, because what happens is that we would write a prescription directly to a school. So even a school we've never gone to, and then the school would fill the prescription, they'd keep a stock supply on hand, and then they'd have discretion to use it later when necessary. States where this has been rolled out, for example, in Illinois, they're having a hard time getting enough providers to write for schools. And so the Attorney General's office has put out a sort of like a helper kit to sort of describe what the law is about, knowing that, of course, there are legal protections in the bill that say if you're a prescriber, if you're a nurse, if you're a school district, you don't necessarily get sued. We're not quite sure how strong that is, but the Washington Medical Association is as confident as they can be, and so is Physicians Insurance. So we're doing our best to try to get as many reassurances built into the bill. But I think it's going to pass.
Why do they need a provider to do it? Why don't they have, like, the state's, medical?
That's a great question. And so if I could change the bill, I'd make it the state could just distribute pens to anyone who needs it. And the reason is that it's still a prescription drug, so it's sort of stuck in the rubric of prescriber, dispenser, administer, so it's kind of complicated that way. We approach this as maybe making a Good Samaritan law, but that's a long ways away. And my assumption is that the makers of ABQ would like for there to be Good Samaritan legislation, like with an AED, but we have to get past the point that it's a medication as opposed to a life-saving tool. And so that's sort of the future. And so I think our next iteration of the bill will probably be where the state can distribute epinephrine auto-injectors. Even I'm stuck in the language. So anyway, but are there any questions about this bill since I'm here? It'll probably pass, I'm hoping, in the next month or so. No? Who's going to write for it?
Have you tried to go through the paramedics to get epinephrine that way instead of going through doctors? Because they're licensed to give it already. And when we tried to get narcotics for our ski patrol at Stevens Pass, going provider-wise, it was horrible. So we went through the paramedics and got it that way, and it was a lot easier to get around the rules. No, it's not illegal.
Legal for them to use it or prescribe it?
Let's get Arda.
All right,
Hi, I'm going to try to go fast. Feel free to ask any questions you want. This Miguel Blanquez, the guy in Spain, has done a lot of the local IgE work, and he that is IgE locally, but not skin test wise. He had 19 patients with perennial rhinitis, nasal provocational test, and non-glycerinated extracts. The nasal provocation test in the U.S. is a bit controversial in that sometimes they're not reproducible. There's a lot of irritant reactions. There was one study from the Midwest where the nasal provocation test didn't correlate at all with the symptom diaries. But the United States study, she used glycerinated extracts. The skin prick test serum IgE was negative to mites, danders, molds. These people had perennial rhinitis who were skin prick test and IgE negative. 94.7% of them were positive to the D. terranissimus in the local challenge. For control, he challenged people with just seasonal allergic rhinitis with the same stuff along with the non-allergic rhinitis controls, and they were all negative. Similarly, 63.2% of patients of alternaria seemed to respond. On reviewing this poster, they used very high concentrations of the extract. Even though it was not glycerinated, it's hard to believe that they don't get false positive ones.
You mean
What's a
skin
positive
test?
reaction? How do they measure it?
They did symptom score, and they also did nasal resistance measurements.
And they had true negatives in the control, even with the high concentration?
Yeah, with the allergic rhinitis, they claimed that none of them reacted with the who were seasonal allergic rhinitis. But I'm not sure how much I totally believe it, but the concept is interesting. Most of maybe some of our non-allergic rhinitis is with eosinophil, even those who are intradermal negative, maybe we might be missing some.
Obviously not double-blinded though.
Do they check for nasal eosinophils on those patients? Did they have it or did they not?
I didn't see that they checked it. But it's food for thought. Clinical characteristics of hereditary angioedema type 3, a very frustrating diagnosis. This is a study by Balkan Gibid et al. They used the Icodabon Outcome Survey database for it out of 9 countries, 37 centers, 108 patients. They found that 15% of them had the F12 gene gain in function mutation, which is certainly a lot lower. It's certainly a lot lower in the United States. They had the diagnosis of type 3 based on family history, angioedema, and/or abdominal pain swelling episodes, and responded to tranexamic acid prophylaxis and/or icodabon, which is definitely not in the United States, at least not until recently. They also didn't. They were excluded if there's urticaria, any responsiveness to antihistamines, prednisone, epinephrine. In this group of selected patients, the HAE3, they were generally older onset. They were 83% female and had more laryngeal swellings. In contrast, I sat in a conference where Conrad Bork, who has all the HAEs in Europe, I shouldn't say all, but the largest patient experience, he thought that the attacks on HAE were tended to be milder than in HAE3 compared to HAE 1 and 2, which is a little different, but this is a bit of a frustrating diagnosis.
He said that 25% of his patients, I think, have the factor 12 genetic defect.
Yeah.
Same range.
Yeah, and this is basically 9 different country experience. There's a couple of things coming up from going into phase 1 studies. This group in Alabama have a small molecule which can be taken orally, which blocks plasma kallikrein. It seems to have an association with increasing PTT and bleeding times. They're planning phase 1 studies for oral use. I suspect that a different dose than would cause the elevated bleeding times. And one other new thing coming up is coming from Diak's group in Massachusetts. They have an antibody that binds to kallikrein that has a long half-life. You inject it, it'll last almost a month. That's scheduled in phase 1 studies. Appears to be fairly safe. Last slide. I like, when my kids were young, I used to bring home a lot of presents for them, and I went on these trips. My wife and my kids asked me to stop doing this, and I just don't know why. So I brought home a souvenir anyway from San Antonio. Any questions? I don't know why they asked me to stop bringing these things.
It's on the slide.
Texas bullshit.
All right.
All right.
Good job, guys.
Next week, I think Dave Naimi is our speaker. Gary, when's your talk on the
April 1st. April 1st.
Oh, nothing controversial. Big bang.
So Oh, okay.
Would you guys feel comfortable
I get aside from
passing that task off?